So what we're going to do now is to move through to the formal deliberation and voting on both the questions related to comparative clinical effectiveness, other benefits, and contextual considerations. Now, I do just need to question the number. We do have, how many CEPAC members? It looks like we should have 1, 2, 3. So there are 14 connections. Maybe someone's connected on both their phone and their computer. But it's showing us as 14 voters. Heavens, we would not want any voting discrepancies in this time and era. So let's see if we can sort that out. Everyone, does anybody know if they could possibly have 2 connections into the voting system at this point? Okay, but won't it show 14 as our denominator? Okay, all right. Wiser heads than I say we can move ahead. Milon, would you please come up and lead the group through its first practice voting question?
All right, everyone. We're going to test the voting technology with the following question. All right, so for those of you who logged into the internet, you should be able to see the slide on your screen. Feel free to raise your hand if you're experiencing any difficulties. Right. We're missing 3 responses.
Read the question.
Sorry, I'm being told that I should be reading the question. So, in 1980, 1990, two thieves posing as copes stole 12 paintings from which Boston area museum? Answer A, Museum of Fine Arts. Answer B, Institute of Contemporary Art. Answer C, Peabody Essex Museum, and answer D, Isabella Stewart Gardner Museum.
Almost there, one more. I think it's probably...
We're missing just one answer.
Yeah,
okay.
It's Ed.
All right, we've got everyone. Right, so I think we should be all set. So yeah, the correct answer was answer D.
All right. Thank you, Milon. All right, so we have a look of confidence, an air of belief that the voting is going to work. Ed and Matt, are we ready to move forward? Okay. Yeah, I think certainly those of us who lived in New England or the Boston area in that time remember that event quite well. Have they recovered the paintings? They did some of them. None of them yet? Maybe there's a movie I saw one year. Okay, so let's move in. So just to be clear that the voting questions are related to the specific patient population, which is patients 16 years or older, consistent with the FDA labels, who have opioid use disorder and are being considered for medication for, I forget how we renamed it, but medication-assisted treatment, medication for addiction treatment. Okay, got it. All right, the first voting question, and these will have a very similar structure as we go drug by drug. So the first question, is the evidence adequate to demonstrate that the net health benefit, and that means the benefits versus the risks, if there are any, of the buprenorphine subcutaneous extended-release injection Sublocade is superior to that provided by transmucosal formulations of buprenorphine naloxone. So let me just, while the council is kind of getting its, we're moving back again to this specific framing of the question, let me invite Reiner to summarize again the basic key findings from the evidence review where they can be found in the evidence summary tables, and a brief, again, description of the thinking of the ICER review team and its evidence rating on this question. Oops, gonna have to grab a microphone. Nope, not yet. I don't think you have to push it.
Great.
Okay, it's on.
This one?
It's on now, you don't have to push it.
Does it work? Yeah, perfect. Okay, so please refer to tables 3, 4, and 5 of the document. So we list the different trials and the outcomes being measured. And we concluded, if you have one of the last slides in the presentation, sort of the comparable effect for different treatment outcomes for most of the medications compared to the comparator. What to say? I don't want to influence you. I think the message is somehow quite clear from our part. We did a systematic review. We compared all existing evidence for each of the interventions, and we made the evidence recommendations, which range between C+ and insufficient. I don't know if you want me to go into each detail of these trials or not.
Reiner, can you please just add a little bit more detail just to help reorient them in terms of the specific findings of the trials on Sublocade? And I believe the evidence rating was I, not C.
Sorry, I'm always Sublocade, sorry. I mean, it's ranging for the different interventions. I put all 4 of them together. Okay, so for Sublocade, the comparator was placebo. So we did not have any direct evidence on comparing Sublocade to the comparator, and we were unable to do an indirect comparison due to the heterogeneity of the trials. So we have no evidence whatsoever on the effect as compared to the comparator.
Okay. Reiner, it would be helpful, again, that being said, the findings of the trial, the pivotal trial of Sublocade versus placebo, can you just help reorient the CEPAC? It's all there on the table, but I'd just like to tee it up for them with some of the specific key data that you think they should look at when they are considering this vote.
Let's start, first of all, table 3, so the phase 3 trial, 20 weeks of duration, times of randomization after induction, and the outcomes were, as in all the other trials, a combination of urine samples and self-report use. For the, let's say number 3, 4, discontinuation in table 4, the percentage of discontinuation, the number of days and weeks retained are not reported. In table number 5, you have the outcomes as of.
For innocent, I think it's hard for
Yeah, okay. For the primary outcomes compared to the placebo. So it's better than placebo. It's very clear. Is it better than the comparator? We can't say.
So just to expand on that a little on the comparator arm and why we had so much trouble with this. If you look at the Suboxone arms, the transmucosal arms of the various other trials, you see wide ranges in what the response rate is because these are really different populations. So to try to look at one trial of Sublocade versus placebo and make a guess about what the response rate would have been had there been a Suboxone arm, we didn't think we could do. And that's why you don't see an economic analysis on that and why you don't see anything more than an I rating.
Any comments on the evidence base from the clinical experts? Any perspective you'd like to share?
I think you've said it all. I mean, I think the clinical evidence to compare the two drugs is, or at least the reported evidence is simply that. It's comparing a drug to placebo. Clinically speaking, the gold standard that by far is more widely used is going to be the buprenorphine naloxone sublingual preparation. And although the populations might ultimately be different that are using them, I think the ultimate efficacy between the two are going to be very similar. One obviously has the advantage of being an extended release preparation, which sort of requires people to take it. But if people took their buprenorphine Suboxone as they were supposed to, I would imagine that the clinical efficacy would be pretty much identical. So it's going to be very hard to know what that group would look like in a trial, since we didn't really compare apples and oranges. I think your point's exactly right. The dropout rate in the buprenorphine naloxone sublingual population varies very much based on the demographic and the social support structures and things like that. So it's really hard to come up with any sort of best guess how it would work in clinical practice.
Yeah, I guess I'll say something on this point as well, which goes to some of the earlier comments, which is there's this sort of saying in addiction medicine that many different approaches work for someone, most don't work for everyone, which is sort of useful clinically but not economically. And it doesn't mean that all approaches are equivalently useful. So, for instance, there are some people who do find an absence-based approach useful, and on the other hand, mortality rates are lower with medication. So I think that I would make that as an even more broad statement to say that the idea that treatment should be available is different than the idea that treatment is better or worse or not comparable to one or another.
All right, thanks. Questions or perspectives from the CEPAC members? Okay. Please go ahead and vote. We got to 12 very quickly.
I got kicked out.
That's all right.
Sorry. Bear with me for 1 second.
Turn off the Wi-Fi.
All right, I'm in.
The Wi-Fi doesn't.
All right. 13 no and 0 yes. All right. So we're not going to debrief a divided vote after that one. The next question, same structure, same patient group. Here, is the evidence adequate to demonstrate that the net health benefit of the buprenorphine subcutaneous extended release injection CAM2038 is superior to that provided by transmucosal formulations of buprenorphine naloxone? Reiner, you're up again.
So we have one key trial, the Loftwall trial, phase 3 non-inferiority, treatment duration 24 weeks. The randomization was done at the start of induction, but the patients were in opioid withdrawal at that point of time. The outcomes, similar to the others, urine samples and questionnaires. You've got the discontinuation rates, you've got the other outcomes, primary and the secondary outcomes. You heard in the discussion from the manufacturer that they said we should have included some evidence that we did not include with a discussion at the break. I just want to clarify that some of their comments, we responded to them in the public comment document after the draft evidence report. So, for example, they say we should include a trial. We said we did not include it because it's a trial on opioid switching and doesn't correspond to the population that we're looking at. I think overall we diverge on some of the points and how to interpret details of the study, I would say, but I'm confident that we included all the evidence, all the relevant evidence into our report. And I'm definitely sure that this does not affect in any way the overall evidence rating that ICER gave to this drug. So we are confident in the work that we did, even if we diverge in some interpretations with the manufacturer.
Yes, Rob.
And Reiner, just to be clear, so this was a trial that did not meet its primary endpoint, correct? Which was responders.
Yep, one of the two. There were two. Sorry.
So
if you want to, well, maybe David.
I believe this was a non-inferiority trial at its base. Am I remembering that correctly?
Yeah.
So I'd be careful about that. If the question is, did this trial adequately show that the drug isn't 10% worse than buprenorphine, I think you could conclusively say it showed the drug is not 10% worse than Suboxone.
Right. But I think the broader question is we were presented data on three outcomes, two of which were designated as primary endpoints, and the trial did not meet those primary endpoints. There was another one that was the mean percent of negative urine samples that was statistically significant, but that was not intended to be the primary endpoint.
So again, just as you're talking about, it's a little tricky if we're talking about meeting endpoints, because the question we're asking is, was this shown to be superior? And I think it's perfectly fair to look at the numbers here in the confidence intervals and think about what the primary and secondary endpoints are in the confidence intervals, and you're seeing that on two of the things listed here, the confidence interval includes no effect, and on one of them it doesn't include no effect. But I'm sure what the manufacturer would say is we set non-inferiority margins of 10% and 11% worse, so that if the question is, did it meet the primary outcome of showing non-inferiority, and if you bought that was a fair non-inferiority margin, which, whether you'd be willing to pay more for an injectable drug that is only 10% worse is a separate question. But on the superiority question, which is what you're asking, I wouldn't focus on did the trial meet its primary endpoint, because the primary endpoint was a non-inferiority endpoint.
Got it. So the question that we're being asked to do, though, is whether the evidence is adequate to demonstrate a net health benefit. So the demonstration of non-inferiority is really not what we're being asked to evaluate.
Yeah.
Yes, that's correct. Okay. Any other questions from the CEPAC? Okay, please go ahead and vote.
So, I'm really sorry. Could I just ask a question?
Oh, sorry, go ahead.
Yeah, I'm sorry. I thought I understood this better than I did. And then, so why was a C+ rating given if simply non-inferiority was demonstrated? Because C+ is in words is moderate certainty of a comparable small or substantial net health benefit, with high certainty of at least a comparable net health benefit.
So if you look at the confidence intervals around the effects in Table 5 on Lawfall, they include the possibility of it being better. Up to, if you look at percent of opioid negative urine samples, the point estimate is 6.7% better, ranging from very slightly worse to 13.6% better. So that's where the plus is coming from.
I see. So that the conversion of that into a evidence recommendation was interpreted to be as C+, which is moderate certainty of comparability. Yeah. Oh.
Moderate certainty of comparability with some possibility that it's better.
That's very helpful. Thank you.
So I have a question. I recall that when we get to the QALYs piece, that the QALYs that are associated with use of CAM are greater than the comparator. How are we supposed to think about the health-related quality of life at this juncture?
I would suggest not focusing on the economic outcome at this juncture. For multiple things that will happen as you move forward, we're going to use the point estimates for the economic model. And these are asking questions of your certainty of the comparisons. And you could have different, the economic model will have its own uncertainties and sensitivity analyses. These are questions about comparative effectiveness.
Okay. Thank you.
Yes. I'm sorry, Lewis, you wanted to have something.
Well, one of my concerns, and maybe Raina, you'll remind me, was the dosing of buprenorphine in the trial, because I think one thing we've learned in the practice, both of induction and maintenance, is if you don't give an adequate dose, people are going to fail. And I know the induction dose was 4 milligrams. We typically start at 16 milligrams. And then I know there was flexible dosing, but we really keep people at high dose as long as we can. Remember, the dose here, from a safety perspective, is relatively irrelevant. I mean, it's a safe drug, but what does change a lot is the efficacy as you go up. And I think we've learned pretty nicely that the 8 milligram dose that we initially started to use is completely non-effective, and you really have to get to 16, 24 or higher doses. So the comparison has to be adjusted properly.
So, sorry, Austin, go ahead.
I was wondering if we could hear from our clinical experts about how we should think about extrapolating, or whether we should extrapolate from urine screen outcomes to all of the other important outcomes. Because I think, right, that's all we have here. Well, we have the responders as well, but I'll go first.
I think the correlation is probably rough. I mean, one of the problems is that I don't know the trials in detail, but there are urine positives and there are urine positives. So there are urine positives that can be quantitated as very high, and those that are very low. Because of difficulty in quantitating levels, it's not comparable person to person. Mm-hmm. So I think the correlation is going to necessarily be rough. On the other hand, I think it is probably fair to say that somebody who has opiates in a number of samples will probably have worse clinical outcomes than somebody who has them in few to none. I think that's a reasonable assumption. And I think you can, in terms of other related health outcomes, you can figure that, for instance, for the part of the model that's about Hep C and HIV, if you have fewer urine positives, you're also going to have presumably fewer injection events and therefore fewer opportunities for infection. So that is probably also correlated to that outcome of the model.
It's a great question, and I'll tell you that the world has changed a lot, in my opinion. So it used to be with methadone programs, for example, if you were positive, you were thrown out of the program. And then they learned quickly that you'd have no patients left in the OTPs because everybody used drugs, and there's just no way around it. So people take a more enlightened approach now, and it's a much more of a harm reduction approach rather than sort of an absolute approach. So the idea that you have to be negative has sort of gone away, and many people don't even do urine drug testing anymore, even though ASAM and a lot of organizations recommend it. What you do with those what you do with those positive samples is very unclear. We often use the word lapse as opposed to relapse, and the word relapse was defined before, and it was defined correctly, which is you're sort of spiraling back down into a drug use den, whereas lapse just kind of means you use drugs. And lots of people lapse all the time but don't relapse, and I know it's a semantic subtlety, but once in a while, if an alcoholic has a drink but they don't relapse again, that's life. And there are a lot of alcoholics who manage to maintain a small alcohol use. So it's a really complicated issue what you do with that. So I think using a hard endpoint that says you must be negative is really tough. And the thing that is even more complicated today is that our urine drug testing hasn't changed since the 1970s, and drugs have. Oh, wow. And there's so many drugs that oxycodone, for example, doesn't really show up on a urine drug screen unless you look for oxycodone. Right, heroin does, of course, but oxycodone doesn't, and that's widely used. Of course, none of the fentanyl derivatives do, which are prevalent now in a lot of our heroin samples. So it's a really hard thing to use. So being negative doesn't mean good, being positive doesn't mean bad. It's a topsy-turvy sort of world that we live in when it comes to drug testing. Very difficult. Mm-hmm. And as a research tool, it makes it it's hard enough clinically to use it, but as a research tool, it becomes even more squishy.
Thank you.
Yeah, I would underline clinically our main reason for doing drug tests is to make sure that we're having honest conversations with folks, mm-hmm. and that they can live the experience of having us know what they did and still have a relationship with them. Yeah. So it's the opposite of condemning them for that result, but having honesty around that result each time. And the big reason that we do testing is to make sure that they have buprenorphine in their system. And so, we sort of, that's very important to us for a bunch of different reasons, both clinically and medical legally. So I just would echo that we are also very much in a harm reduction mode, and there's an Annals of Internal Medicine commentary that came out recently that kind of underlines, I think, a lot of how the field has shifted just from recently.
Somehow I'm not sure, this isn't really a policy, it's certainly not a recommendation, but just as an insight, the way you just said that a major goal of urine testing is to show that they're taking the buprenorphine, it just really flips the whole idea of dirty and clean and all the other kinds of stigma things associated with urine testing through the years, and really helps put it in a very different light. So that's very helpful. Any other questions? Yes, Jean.
I just need some more clarification from Dr. Nelson on, so I think what you were saying is that Suboxone may have underperformed in that study?
Right. I mean, if you design a trial, if you compared, one Tylenol tablet to 10 milligrams of morphine, the morphine's going to do better, right? I mean, but if you give the right dose of acetaminophen, you're going to, so it depends how you design the trial. A 4 milligram dose for induction is very low. Nobody would do that. We start with 8. We usually go up to 16. And then, how you define flexible dosing regimens, if they're, many of us use doses at 16 and 24 routinely, a lot of people are still using 8. I mean, the tip that came out, the treatment program, they're still recommending a low-end dose, and I don't want to speak for everybody in the room that does this. Everybody does it differently. So flexibility might be a good thing, but it also might be a problem depending on who it is that's performing the trial and what their endpoints are, what their end goals are. In the trial? Okay, it doesn't say that. Okay, well, if that's true, that's fine. I mean, I don't know if everybody heard what he said, but I don't have that data in front of me. So I'm just raising it as an issue, and maybe if it's not true, maybe.
Just so people online, because it wasn't audio recorded, the comment came from someone from the manufacturer that who knew the study and the way it was, the protocol, how it was done, who said that the titrated dose of Suboxone was 24 milligrams. Okay, any other questions from CEPAC on this question?
Yeah,
Jason?
so
Yes.
I'm sorry, I thought I was more concluded than I was. I just wanted to confirm, first of all, that the paper that is being referenced is Loft-Wall et al. In JAMA Internal Medicine. Is that correct? And so do we know what proportion of patients were titrated up? I know the protocol allowed for that, I understand, but do you know what proportion of patients were titrated up?
Sure, please. Can you turn on his mic?
If patients were allowed 4 or 8 of sublingual, that's not a fair comparison. But for both the extended release buprenorphine and the sublingual, we allowed patients and clinicians to decide on an adequate dose. So we had I don't think we had anybody on 4 I'm talking about the sublingual, and the majority were spread between the 16 and the 24 of the sublingual. I don't think that's in the paper, but we have that data. And then you saw the data in the paper for the extended release buprenorphine, where the majority of patients titrated up to the higher doses of weekly, and then in turn in the monthly. And then if I'm happy, and I know we don't have time, if there's other clarifications of the actual study and the study data and the primary endpoints, happy to clarify. I think it's important that the committee hears all the data.
Understood. Thank you.
So, thanks.
Any other questions? All right, please go ahead and vote. Is the evidence adequate? CAM 2038. A is yes, B is no. All right. We have 9 no and 4 yes. Since we have a few people saying yes, is anybody interested in just kind of clarifying what their thinking was that led them to vote yes? Anybody willing? Jason?
Yeah, I'm happy to clarify. I mean, I went back and forth on this a lot. I mean, I think in the end I'll say I voted yes with some concern. I mean, I think, I was actually pretty concerned about the issue with the comparator group and the dose. And we have to say, is the evidence adequate? I mean, a lot of this is, so it wasn't reported in the paper. That's like a little challenging to interpret in terms of whether the evidence is adequate. So I still have a lot of concerns about it. But at the end of the day, I was persuaded enough that the let's call it a surrogate endpoint of the urine samples was a reasonable approximation of clinical benefit. Although I have to say, and I'd appreciate if these comments are in some ways incorporated in the final report, is that I'm challenged both by the comment about adequacy of evidence, especially if that particular pretty serious concern wasn't articulated and it wasn't reported. And I also have some still concerns about the urine samples as a surrogate endpoint for endpoints that are more meaningful to patients.
Okay, thank you. We'll note that in the report. Any other strikingly different or important perspectives on the votes that anybody would like to put on the table? If not, let's go to the next voting question. So again, same format. Is the evidence adequate to demonstrate that the net health benefit of buprenorphine implant probufene is superior to that provided by transmucosal formulations of buprenorphine naloxone?
Okay.
Reiner?
So again, probufene is the implant, as you know. It's the one key trial, Rosenthal 2016, phase 3 non-inferiority, 24 weeks. The outcomes, we just spoke about the outcomes. Again, urine samples and questionnaires. One of the important points for probufene is the question of the dose. We just spoke about the dose, so it's 8 milligrams or less, which is only a small part of the population with OUD users. The outcome was superior for the responders, which actually show that you can have a superior response in non-inferiority trial. Otherwise, I don't know what else to say.
Can you please then justify the promising but inconclusive, and why did this why was this different than the C+?
The promising inconclusive comes from the study population, because we said the population of interest, 16 years of older with OUD, considering an MHE treatment. So among this population, only a very small percentage would be taking in the end probufene. Also, probufene is of limited value, as it's a 1-year use at the maximum, not more than that, because you cannot re-implant the same implant in the same arm, one arm, and that's at each time, and that's it. So mainly because of the study populations, we said comparing the population to the population of interest, that's inconclusive.
Just to make sure people understood the point that Reiner's making, you couldn't have been randomized unless you were able to get by on 8 milligrams of Suboxone to be able to be looked at. And the population we're looking at is clearly more broad than that. You've heard that it's the rare patient who would be getting by on 8 milligrams of Suboxone. So that's what led to our not being able to rate it better than this for the actual population we were looking at.
Is that part of why, can you just, one thing I can stress, the difference in the way these studies were designed to the populations, but the responder, active, probufene versus Suboxone, 96% versus 87%, versus the arms in the CAM 2038 arm were 17% versus 14%. Why such dramatically different ranges for what should be the same kind of outcome?
These were patients who were already doing well
right.
on 8 milligrams of Suboxone before being randomized.
I just wanted to make that clear because it stands out, obviously. All right, questions, or is there any comments from the clinical experts on the data on probufene?
No, I think what you've said already is pretty adequate. This drug applies to a very small percentage of the population overall. And clearly it's not a widely used drug because of the mechanism of implantation and the duration of 1 year that you can use. There's a lot of sort of clinical implications with using it. And, many people don't want to go through the trouble of learning how to implant it and remove it. So it doesn't have that, it does have that disadvantage. And I think that, as has been commented, the 8 milligram limitation really brings you to a different population. Because if you can get by in 8 milligrams, you're not the same as somebody who requires 16 or 24 milligrams. Your craving might be less, your pre-morbid conditioning might be different, you might have better social support, so it's not really the same population. It's hard to compare these things.
Okay, good. Joe, anything else?
Yeah, I would agree that it's a subpopulation. Again, to be fair, there's a set of people for whom that dose is fine, and for whom the implant might genuinely be, a useful thing. I think, for instance, in the setting of somebody whose work is part of what keeps them in recovery, then having something that allows them to be adherent and possibly have fewer visits is reasonable. Again, that's not something that the data tells you. It tells you that, you can decide what it tells you. But on a clinical level, I would agree that we have not spent much time thinking about the implants in the sense that we just have a different population.
Yes, Austin.
So can you advise us whether we're interpreting adequacy of the data? The question here, with respect to the subpopulation that this is intended for, or for the entire population that was the premise of the whole set?
Well, the team was considering its representativeness of the broader population for which other options for MAT could be considered. So I think it would be in that spirit of the broader population, not just those who are adequately controlled on 8 milligrams.
I have a second question, but I predict you're going to want to put a pin in it for later, which is, it's a question of whether this is a... Yeah,
I'm poised, I'm ready.
Is this a technology that could expand to allow higher doses later? Is this an emerging technology?
The reason I'm putting a pin is because I have no idea.
Well,
and the company itself, the company's not here today, so unless the clinical experts
I don't think that pertains to actually this exact question, but
yeah, I'm not sure it really.
It's important about whether it's an emerging technology that we should support for middle.
Since that's not central to a judgment of the evidence today,
I'm advising
your instinct is correct. I should put a pin in that, and it will come back as one of the other potential other benefits, perhaps, or other things. You want to stand up here, Austin?
No, I don't.
Good job. Good job. All right. Any other questions? All right. Please go ahead and vote. Waiting for one more, I hope. Okay, still waiting for, has anyone not voted yet? Raise their hand. That's what I thought. Something's up with the system. Can we quickly check around and see if everybody's vote looks like it's being recorded? Sorry, folks, we're just missing one vote on the tabulation.
Like a proctored exam.
All right, well, if it ends up being a 6-6 vote, we'll have a problem. But, oh, there it is. Somehow it just came through. 12 no and 1 yes. All right, for the sake of time, I think I'm going to keep going. We're going to start to get into some of the questions. Oh, I'm sorry, I forgot. We still have one more of these with Vivitrol. Apologies. So, same patient population, same format of the question.
So, Vivitrol, the only one with an antagonist action. We have got 2 key trials in Table 3. One is a Phase 3 non-inferiority trial over 12 weeks. The other is a Phase 4 trial over 24 weeks. outcomes, same types of outcomes. For all of these studies, the outcomes are slightly different defined, but it's the general types of outcomes. The discontinuation rates are reported in table 4, and abstinence and relapse in table 5. The relapse rate is increased with intention to treat analysis compared to oral transmucosal buprenorphine.
Okay, Reiner, table 5 I don't believe has any data on Vivitrol.
On the other side.
Right, is it on the other side? Yeah. Oh, sorry. The continuation of table 5 does. There it is. 2 studies. All right. Questions from the CEPAC? Yes, Ed.
Question for the clinical experts.
Sorry, can you use the mic?
Question for the clinical experts. I know we heard that there's no evidence that tells us there are populations that are better suited for different treatments, but in your clinical experience, you may find that there are differences. In my experience, there are differences, and I'm struggling with thinking of Vivitrol as potentially suitable for the population that we're talking about.
I'll say 2 things about this. One from kind of what my patients talk to me about that medication versus what I worry about or think about with that medication. I think for many people, for correctional facilities, for various elements of society, the idea of having a non-opioid treatment for opioid use disorder is attractive on a lot of levels. The various reasons why that is attractive to them are complex and interwoven with what I would view as helpful and unhelpful parts of that. I mean, I think the sort of notion that agonist or partial agonist treatment is, quote, switching one drug for another. You can just use the example of caffeine dependence of an example of physical dependence without adverse consequences. And addiction or substance use disorder is use despite adverse consequences. So we don't think of it that way, but some people want no part of their mu receptors being activated. I think the people coming out of prison, particularly for long stays, who, for whatever reason, have not had access to opioids in prison, which is a subset of the prison population. So their tolerance really is low, and they have not actually used for a long time. I think Vivitrol, and there's some trials to suggest Vivitrol is useful in that population, in that you're protecting against the very high overdose rate after release, but they're not experiencing a kind of opioid sensation that reminds them of that past experience, and that's what some people say. I think there's another phase in which I unfortunately don't get to use it that often, but which patients often contemplate, which is after an extended period on agonist treatment or partial agonist treatment, if they want to come off of medication and kind of make their lives simpler in a number of different ways, then you could imagine Vivitrol as being kind of part of the intermediate period of not using an agonist, but having, again, some protection against overdose. So, those are all places where we might think about using it. And as I said earlier and won't dwell on, the thing we fret about is lowering tolerance. So in Massachusetts, Chapter 55 data shows that people who have been released from prison have a 120 times higher rate of death from overdose than the general population. And most of that is accrued in the first few weeks after release. So the worry, there's a bunch of other things that contribute besides the loss of tolerance to that overdose rate, but the worry is that losing tolerance would contribute to some portion of that elevated risk. So, and again, we are forced to rely on some degree of clinical intuition in making those decisions.
Yeah, I fully agree. I mean, the post-corrections patients really do well on this medication, but because they're no longer dependent and they have lost their tolerance. The other group that does well are people in sensitive work positions, like law enforcement, physicians, truck drivers, airplane pilots, people that really shouldn't be on agonist therapy. Because of sedation and other things. Not that it's a bad thing to be on, but it's certainly a lot easier not to be on it. So they do pretty well on it. I've had a lot of people who haven't been able to tolerate this because you lose a lot of sort of the pleasures of life when you're on this medication, because a lot of euphoria and good feelings and things like that come from endogenous opioids, which you no longer really can. And so people have a sort of a dulled lifestyle, so to speak. So a lot of people just don't really like to use it. Again, if it's court mandated, like it might be, in certain situations, people don't have a choice. But I've had many, many people, whether it's oral naltrexone or long-acting naltrexone, they just don't really like it. That being said, if you can tolerate it, it does have the advantage that it's really hard to overdose, and it's really hard to abuse opioids. People do switch to other non-opioids in preference. You can switch to lots of other, amphetamines, benzodiazepines, pick your other drugs. All of those are completely unaffected for the most part. So, that's not obviously factored into a lot of decision making. And typically people like opioids, but there's a lot of people who take whatever they can get. So there are good and bad of the drug, and it is a niche, and for the population that benefits from it, I think there is definitely a benefit.
And we're definitely coming back to this topic during the policy roundtable, specific populations. All right, so you have the evidence from the trial there. I think it was mentioned, but the relapse rates for Vivitrol in the head-to-head versus Suboxone were higher. The ICER evidence rating was C, and I think Reiner explained why. So any questions from the panel? Okay, please go ahead and vote. Oh, okay. And we've got all 13. Milan, should I go ahead, or do we have Steve's vote?
Actually, it was done in the
Pardon me?
previous question. He has only the previous question displayed.
Okay, well, I have 13 responses to this question.
They might be using the internet at the other conference too. It might slow down the.
All right, I'm going to go ahead, and if it's a close vote, we can, okay. 11 no and 2 yes. We'll assume that was the vote. One vote, one way or the other, is not going to make a big difference in the interpretation thereof. Okay, one more clinical effectiveness question, and then we're going to have to pick up our pace, and that usually means me doing it as we move into some of the other questions. This one is a little bit tricky, but it's about being able to distinguish the net health benefits among or across these three different agents. This is a question that does come up a lot in payer and other policymaker thinking about how to consider these drugs. It may not be as central to clinical care, but in some ways it's obviously important there too. So the question is worded, is the evidence adequate to distinguish the net health benefit among the following interventions? The 2 buprenorphine subcutaneous extended release injections, Sublocade and CAM 2038, the buprenorphine implant, and naltrexone, intramuscular extended release injection, Vivitrol. So the question, yes?
So we've already acknowledged that some of these are by design for different populations than others, and so that almost makes this an impossible comparison on those grounds.
Well, remember, I advised you for Probufene to think of it in the same population.
Yeah, but
the broader indication for that population. So with that caveat, with that pin still up in the wall, the populations are the same. Now, we've heard that clinicians think about specific life situations and many other characteristics that go into the tailoring of a choice for an individual patient. We're coming back there. It's a critical piece of translating the evidence into practice and policy. Here we're trying to say, is the evidence help you? And again, you could do a logic A if A, then B, then C, but I'm going to let you guys vote on whether the evidence is adequate to distinguish among these options. Any other questions? Okay, please go ahead and vote. Steve, are you back online the way you need to be? Okay, good. Okay, 12 no and 1 yes. I'm going to keep going for the sake of wanting to make sure we have enough time to talk about the other benefits and contextual issues. Apologies to those of you in the audience. I hope the font is big enough for you to still be able to see, and similarly for those watching through the webcast. The purpose of these, again, is to try to capture certain things that may be important for all policymakers and clinicians and patient groups, et cetera, to think about when they're thinking about the value of these treatments. So again, we will dive into different patient subgroups as a part of this, and we'll flow right into the policy roundtable on those topics. But we're going to have a specific vote, and it's going to be in several rounds, because we want to ask them somewhat separately for different new options. So we are going to group together the sub-Q injections. We're going to have the implant separate and Vivitrol separate because of its different mechanism of action. So, does treating patients with one of these interventions offer one or more of the following potential other benefits versus what we are kind of calling the standard of care, standard approach, transmucosal formulation of buprenorphine naloxone? And the key to your voting here is that you're going to select all that apply. So there's no minimum or maximum number of votes. There's also, and I'll read these, but just so you know now, there's a J down there that says any other important benefits or disadvantages that we have failed to identify or that you want to make sure gets stressed in some way. So, CAM 2038 and Sublocade versus transmucosal formulations, do they offer reduced complexity that will basically have a potential benefit compared to Suboxone? I'll just start saying that. Probufene, then the same question, and Vivitrol. The next one is about whether these treatments altogether would reduce important health disparities compared to current use of oral buprenorphine naloxone, reduce caregiver or broader family burden. And again, important not to think about them just as treatments, full stop, but as treatments compared to Suboxone. Okay. Do they offer a novel mechanism of action or approach that will allow successful treatment of many patients for whom oral Suboxone does not work or has failed? Then the same thing for Probufene and Vivitrol. And we have for I, it says, again, compared to the Suboxone, do any of these or all of these have a significant impact on improving return to work and overall productivity? So it's a really tough thing to kind of lump and split these questions sometimes. The major goal is to try to make sure that we capture in the report and for people, thinking about the votes, the potential for these other benefits or disadvantages to be significant and to be missed somehow in the clinical effectiveness and the cost effectiveness considerations. This is tough. Awesome.
So as I look at these, the only one that I think I haven't heard a single word mentioned about, unless I missed something, is caregiver burden. The other was, I think, in some way I've heard discussed today, but can we talk about that?
Sure. I'll just tell you conceptually what it's meant to imply is that usually it's from a new treatment that will be measuring its impact on patient clinical outcomes. Let's say it's helping a child breathe better, and what won't be captured in the clinical trial is whether the ability of that child to breathe that much better allows the parents to go back to work, allows them not to have a full-time sitter, that it can make kind of a step change in their burden and And again, parents don't like to talk about burdens of caring for their sick children, but you get the idea that there's a significant impact on the broader impact of caregiving that is missed in the trials.
So there's no question in my mind that successful treatment of OUD will have massive impact on that person's family.
Versus oral
But
buprenorphine.
Oh, I see.
That's the key here.
Okay, I understand.
Other questions as you start to think through? Again, you heard a little bit about some of how we gathered patient testimony, and again, unfortunately, the patient representative that we've been working with was unable to end up making it today. Reiner, you had one slide. I'm not sure. I think folks probably remember it, or they can go back and look at it. And for the sake of time,
You can also look at table 12 in the Evans handout.
Oh, good.
Table 12 relates to the question 6. But I don't think it captures the discussions we already had today.
Yeah. Sorry, I forgot it. I forgot it was in the evidence summary. Good. Okay, any other thoughts or questions as you guys start to vote through this? Okay, I think we've had some, and again, some of this will bleed into the policy roundtable in an important way. But why don't you go ahead and complete your votes for all of the above that apply.
Thank you.
Please indicate whether you think they offer one or more of the following potential other benefits versus Suboxone. All right, and because the way this works, I won't know when you're all done because I can't use the counting mechanism because you'll be having multiple votes. I'm just going to look at you, and when you're done, look up at me, and I'll try to figure out when we're ready to look at all the votes. Okay, who's still working on their votes? Anybody? Okay. Ed, you look done. I think, Al, you're still working, right? All done? Okay. I hope the results come up in a way that you can interpret. I'll just kind of quickly reflect. So again, with 13 voting members, we can see that 10 out of 13 suggest or voted that the sub-Q injectable forms offer reduced complexity that can help patient outcomes. 4 with Probufene, 8 with Vivitrol. You can just see the disparities. We've got 7.
Technical problem.
Caregiver burden, 6. The injectables, a new mechanism of action that can help others who weren't able to be successfully treated, 7. Probufene, 3. Vivitrol, 8. Significant impact on returning to work versus Suboxone, 5. And we have 7 J's. So let's quickly try to capture some of those J's. Sometimes they are really helpful. Yes, Stephanie.
My J was stigma. I think some of these, particularly the injectable options, offer a potentially less stigmatizing experience for some patients.
Okay. Any other J's? Yes, Jean.
So my J is that clinicians and families that I have heard from need more options. That said, I know this isn't the right time in the meeting to say this. I am really concerned about the pricing on these, but people desperately need these options and improved and greater access.
Okay. In some ways, I think people feeling that same way probably would have ticked the box around either different mechanism of action or something, but we'll make that very clear that there may even be somewhat of a separate issue around having the multiplicity of options for any number of reasons is
I think it is beyond the individual comparison, but again,
Yeah.
multiple options and
Yep.
greater access.
Okay, thanks.
I also want to comment on the health disparity of rurality. As you know, a lot of New England is very rural, and again, that's an important aspect for me.
I'm going to come back to the question about whether actually these any of these formulations will in some way affect the number of doctors or clinicians who can prescribe these drugs, if there's some linkage to access that is also kind of a structural feature. We'll come back to that too. Any other J's that people want to? Yes, Steve.
My J was the issue of diversion of sublingual buprenorphine, and although it was mentioned as perhaps that's a positive in some regards, I can't imagine it's entirely positive.
All right, and I'm going to come back to that in the policy roundtable. You guys are good table setters here. Yes, Claudia.
I had two of them that I was considering. One is with the different modalities, the potential for loss of tolerance and overdose deaths with a lack of access to therapy that might result with some of these medications. And the other aspect was how we're using buprenorphine now in the emergency department. We're starting treatment directly in the ED, and how some of these medications may be more appropriate than others in the new model that's evolving for treatment for opioid use disorder.
Just so I'm clear, so you mean that there might be something distinctly helpful about having an injectable version in the ED as they transition back into the community, or is there something else that I'm missing?
Well, I think that that's a good possibility. It'll be very interesting to see how CAM 2038 is utilized, whether it might be utilized in that type of setting, and also with the type of medication treatment that we're offering in the ED, it affects the utilization of Vivitrol. I'm not quite sure how it's going to, how guidelines are going to develop in the new model that seems to be developing.
Okay. Certainly provides more options as guidelines are created to think about different delivery mechanisms and how that might fit better in certain approaches. Jason, you have a J?
Yeah, I have a J that's aligned at least with some of the other J's, but a little bit different. Is that one thing I always struggle with in a lot of these sessions is distinguishing average treatment effect and heterogeneous treatment effects in clinical trials. So there's nothing wrong with this. No one can do any different, but we're using average treatment effects. That's the only way to do it. And extrapolating this to make conclusions about comparable clinical benefits and then also ultimately cost effectiveness. But at least conceptually, if you have, even if treatments are near similar in terms of their benefit, the potential could be for the population to benefit more with more treatment options as doctors in the future learn how to discriminate between patient A benefits from this one and patient B benefits from that one, at least conceptually, so that the whole population could do better with simply more options available, even if the average treatment effect is similar. Now, so this is entirely speculative, I know, and so it wouldn't change any of my votes, right, because it's nowhere near a sufficient evidence to say that this would be the case, but at least there's a potential of that, and as such, I think there's a benefit to having more options for clinicians. And I would say this because I think the research needs to be done, right? If these things become available, we need to understand better if there's certain types of patients, and especially in this population, right, because there's such different life circumstances and pathways into opioid use disorder, that there really is a potential, at least, for this type of heterogeneous treatment effect to become clearer later. So that was influential in that J for me.
Thank you. I think it actually does dovetail well in some ways with what Claudia was saying.
Other comments.
Good. Any other J's? These are excellent. Anything else? Okay. Unfortunately, we're going a little bit over time, but that's okay. We'll have to cannibalize the break a bit. But let's keep going. There's another 2 slides. We're shifting to contextual considerations. So these are slightly different than potential other benefits. It's around issues that sometimes come into play when people are thinking about health benefits and who gets them. There's social values around things like severity of illness, kind of the duration of the condition and its lifetime burden, if you will. So let me read these, and then we'll do the voting or discussion and voting. So are any of the following contextual considerations important in assessing the long-term value for money of the extended release interventions? So again, this is sending a signal to policymakers that in looking at the clinical evidence and the cost effectiveness, the budget impact, if you will, too, what contextual issues are perhaps very important in helping to weigh the different, those different aspects of value. So let me just read through them. So this is a situation, and we're talking about the care of individuals with a condition of high severity, care of individuals with a condition with a high lifetime burden of illness, whether this treatment, and I'm sorry, this really should be in comparison, I'm sorry it's not up here, but this should be also in comparison to current treatment with Suboxone. So it's not like we're going back in time and there's no other treatment available, and these are the first options. So we've got Suboxone, now we've got these new options. Is it the first offer any improvement ever for this condition? Then we break down some by individual drugs. So is there a significant uncertainty about the long-term risk of serious side effects with CAM 2038 versus Suboxone? Same for Sublocade and Probufene and Vivitrol. So we're going to vote on this set, and then we have one more set of contextual considerations. So you can start to vote if you wish, but this is also your opportunity to ask questions about context or to make comments so that you can share the way that you're thinking about this with the fellow CEPAC members. Stephanie.
Great, thanks. I have a question for the experts here. I have some concerns about Sublocade from a monitoring, treatment, participation, rapport kind of perspective. I don't know what your thoughts are about that. You give patient the drug that is going to last for a full month. It may reduce their desire maybe to come back for therapy or other sort of parts of their treatment.
I don't actually see that as a big issue. I tell you, one of the drugs that we have the best compliance with are the opioid agonists. You know, you can't get people to take their blood pressure medicines or their seizure meds, but everybody takes their opioids. And I think that if they don't come back, they're going to go through withdrawal syndrome just like anybody else, but it might be muted because it's buprenorphine and it's slow to wear off. But I don't really think compliance is a big problem. I mean, the problem you do see, I mean, even when we make people come back from methadone, they still come back. And when we start people on, buprenorphine strips or tablets, we'll often give them a month of treatment anyway, so we don't expect to see them for another month. So I don't think that that's going to turn out to be, I don't think that is currently a significant concern. In terms of if that's what you're, maybe I'm not answering the right question, but if that's the question, I think that it's not, to me, it's not a concern.
No, you're answering my question. It sounds like your practice is maybe a little bit more comfortable with longer-term prescriptions than the patients that I experience in my practice.
Yeah, I mean, most people that do either office or clinic-based buprenorphine treatment do not make people come back on a regular basis. I mean, that defeats the whole purpose. That was one of the problems, of course, with methadone clinics was sort of the coming back and on a daily basis, interfering with your ability to get functional employment and then seeing your friends back. I mean, there was a whole lot of problems associated with that, which sort of went away when we went to office-based therapy. Most doctors don't want to do office-based therapy, so it's kind of become clinic-based therapy, but at least it's not daily clinic-based therapy. So I personally think it's a better option.
I think we're a relatively high-touch program for some other reasons. I think we have a population of people who gets 28-day prescriptions, and so for that population, I think it would just be, better adherence, sort of more guarantee of adherence in the midst of it. I think I also, unfortunately, the value of therapy for addiction outcomes narrowly defined is, not clear. So I think it's in your review, it talks about the fact that, additional behavioral, the Cochrane reviews kind of show that additional behavioral health interventions in addition to the medication haven't had, really appreciable effects for the most part. You could ask, well, then why do we have a bunch of therapists in the program that I run? And in our case, the reason for that is the comorbidities that our patients almost universally have. And so I think there is evidence for therapy for PTSD and for anxiety and for depression, and that those are driving some of our patients' related challenges. So we still think that's important, and we think a high degree of engagement is important with our, again, our very extremely high-risk, disenfranchised population relative to the OUD population as a whole. But all that caveat aside, even we have 28-day scripts. The marketing advantage of the CAM product of the weekly going to monthly is sort of obvious for a program like ours, but again, for people who are monthly already, there's not an inherent difference.
Right. Okay. Thank you.
Yes, Claudia.
Just a clarification that I may have missed. When we're talking about the long-term risk of serious side effects of the medications, are you narrowly defining that question as specific to the medication?
Yes. And to make it a little bit easier for you, again, this is kind of comparing a different delivery mechanism of the same drug to the drug. So it's probably a little bit more self-evident than some of the other contextual issues. All right, I think we're going to go ahead and vote on these. Just to note, for the voting aficionados, one member of the CEPAC had to leave for a family medical emergency, so we're down to 12 votes. That will be the denominator. So please go ahead and vote on all of these that should be viewed as important by policymakers when they assess the long-term value for money of the new treatment options versus Suboxone. Again, I'll be looking for faces to see when they're done. Okay. Stephanie, you're still going, right?
I'm good.
You're done? Okay. Everybody's done. All right. So high severity, 11 out of 12. Care of individuals with a high lifetime burden of illness, 12 out of 12. First to ever offer any, 0, and you can see the numbers are smaller thereafter. So again, partly for time. There's one more of these, and they kind of continue on with some of the other issues around uncertainty. This time it shifts to the questions about uncertainty about the magnitude or the durability of the long-term benefits of these current versions versus the oral versions. So for what it's worth, that's what we're trying to understand. In some cases, there's a new approach that is obviously a very different approach and might offer very different types of uncertainty around the long-term risks or benefits. This is asking about significant uncertainty about magnitude or durability of long-term benefits of all four. And then we have an E again that will open up to the floor if you guys have other important contextual considerations. Is there any discussion? Yes.
So probufene is sort of by definition time limited, right? It's 6 months and then maybe another 6 months. So I'm not sure how to address the question of uncertainty of long-term benefit because there
are none.
There's none.
Yeah, right, exactly.
Yeah.
Okay, fine.
So it would not be an important thing to worry about
Okay.
in another way of saying it. Yes?
But couldn't it be an uncertainty of what happens next and how a second phase of their treatment will interact and what they're open to taking next?
Well, I guess it's an interesting point, just for a sec, because, we did raise the question, the point that depending on what drug they take after the probufene will have a big impact on the cost effectiveness, which is part of the value. So I guess you could say there's that. But about the drug itself, I think we should focus just on the drug itself in terms of uncertainty about its benefit. So I think we made the point, and we'll bring it up in the report, that what drug is taken after probufene has a big impact on how you would model its cost effectiveness. Any other questions or comments on this set of contextual issues? Okay, go ahead and vote, please. Got it. Al, you still working on it? You done? Okay, I think that's it then. Okay, so we have significant uncertainty about the magnitude of durability of the long-term benefits of CAM 2038. I'm not going to read the whole thing again. 992 for probufene, 9 about Vivitrol, and we have 6 E's. So let's capture a few of those, if we will. Yes, Jean.
So I think families I know would like to have had their child live long enough to worry about the durability of the benefit.
I'm sorry, can you, maybe it's the microphone, but I couldn't hear you that time.
I said, I think families, I'm probably a little emotional. I think the families I know would like to have had their child live long enough to worry about the durability of the benefit of these drugs.
All right. Yes, Austin.
Oh, I just used E to kind of mark my thought about the technology of probufene and whether that could emerge to be more than it is today.
Okay. Well, I'm going to weigh that as an other benefit, so
Yeah,
I'm not
okay,
going.
that's
I'm not
fine.
going to give you double credit. Because I think that's a very good
I never
point.
indicated it
We'll
before.
capture that as a
Fine,
potential
thank
other benefit. I understand what you're saying. It's part of the context of innovation, but
Yeah.
we'll put it on the other category. Any other E's that people wanted to introduce? Yes, Claudio?
I think the social stigma, and speaking to what the chief brought up earlier about if there's more and varied options, and if the stigma both from a family perspective, social support perspective, and provider perspective can be better addressed with just simply having more options, even if on an individual basis, none of them are the golden bullet. I think that's an important consideration.
Okay. And Steve, did you have one too?
I was considering value from the societal perspective, and ultimately the price of generic buprenorphine will continue to drop, and we'll be able to extend therapy to more patients. And the relative value of the more expensive products, contrastingly, will rise.
Will rise? The value will rise? You mean?
The price will rise.
The price will.
The ICERs will, yeah.
So there, in a sense,
It'll be less valuable.
so you think
comparatively.
there's a contextual consideration that if the price of the generic version continues to fall and the price of the brand stay the same, that their value will actually worsen.
Right.
Okay.